You're watching CTOM TV. Knowledge is power.
So we're going to go into treatment now. We're going to be very brief about this, but general considerations. In some cases, high grade can develop from low grade.
Okay.
So it's always important to have your pathology redone over time. So if you have low grade ovarian and you're not responding so well to the treatments anymore, definitely get your pathology re-looked at, get a new sample and see if it's converted to high grade. It does happen.
Okay.
It's not the most common thing, but it does happen, and it's important consideration because the treatments will be very different.
But in this case, if somebody didn't want to go through the process of another biopsy, which could be understandable because it's not a pleasant process necessarily, we could at that point use the liquid biopsy.
Yeah, we could look at genes that are unique to high grade versus low grade.
So you could just have a blood test rather than having to go and have a whole nother tissue biopsy taken.
Yes, exactly. Yeah. So the main treatment typically for high grade is surgery, and once again, you want to have everything removed.
Okay.
So once again, this transition zone in the fallopian tubes is where these start.
Yeah. So if your oncologist is not recommending the removal of fallopian tubes
and everything,
then you may want to either provide them with more current data or change doctors.
Exactly. So the standard chemotherapy is platinum-based drugs and taxanes, as they call them, paclitaxel. For prognosis with standard chemotherapy, if you have overexpression of a gene called P53, which is the guardian of the genome, as they call it, it's involved, it's a tumor suppressor. It's one of the first tumor suppressors ever identified, and it's called the guardian of the genome. It's the most altered gene in all cancers.
So what they're saying is if it's working well, you have far less likelihood of developing cancer.
If you have expression of it, it's good.
Okay.
You're going to have a good response.
Okay.
If there is an expression of it, you have a high chance of recurrence with the standard platinum and taxane-based chemo.
Okay. High chance of recurrence.
Yeah. Now, on that note, I think it's about 97% of high-grade ovarians have mutations in P53.
Wow.
Yes.
That's huge. That's
and you don't see these in low grade. You do see P53 mutations in mucinous, but you don't see them in low grade, and that is one of the defining factors between the two. So
96%, that's quite prevalent.
Yes, huge. Yeah, definitely. There's also germline BRCA1 mutations. They're about 10%. BRCA2 mutations, germline, about 5 to 6%. And then somatic BRCA1 and 2 mutations are around 6, maybe 7%.
Okay, so for those at home, the somatic
versus the germline.
Right. Yes. So germline is what you're born with.
Yes, it's in every cell in the body.
And somatic is what's
only in the tumor.
Yeah.
So you're not passing those on. And then mutations in a set of genes that are associated with the BRCA1 and 2, and they're called homologous recombination genes. And so if you have mutations in these genes, then you have what's called homologous recombination deficiency. And so if you have that, about 17%, maybe 20% of patients with high-grade ovarian have that. Then you're going to have an excellent response to platinum-based chemotherapy. But it also opens up the door for treatment with PARP inhibitors. So we've talked about PARP inhibitors before. They're a great new treatment for many different cancers, specifically towards those with mutations in genes involved in DNA mutation and repair, such as homologous recombination, such as the BRCA1 and 2. So if you have BRCA1 and 2, PARP inhibitor, typically, and that goes for prostate cancer, breast cancer, but they were first discovered in ovarian cancers. So PARPs were first used in ovarian cancers, and that's where most of our data comes from. So right now we have 3 FDA-approved PARP inhibitors. They're approved for platinum-sensitive disease. That means, women that have responded to the platinum-based chemotherapy. And then we have one that is being tested.
Okay.
So the approved one's olaparib, which is one of the first PARP inhibitors ever. And that is being used. The most promising approach with olaparib right now is to combine it with Avastin, anti-angiogenesis. And that definitely improves progression-free survival and overall survival rates, specifically in women that have BRCA1 mutations or HRD mutations, so homologous recombination deficiency. Okay. Which once again is about 20% in these cancers. Okay. So there's another drug, a newer version called niraparib. It's a good drug. It reduces the progression of disease by about 30%. 40%. Okay. And up to 60% in women that have BRCA mutations, so it's quite significant.
That is, yes.
It's being approved for newly diagnosed high-grade or endometrioid or primary peritoneal or fallopian tube. Okay. And, typically for women that have BRCA mutations specifically. There's another one, rucaparib. I haven't really looked at the data on that lately, but that's being used too. And then veliparib. Okay. Veliparib. That's the newer one is being tested. So that one seems to work fairly well. Okay. And so that has a progression-free survival in BRCA mutated patients of 34.7 months versus 22 months for patients not getting that with a BRCA mutation. And once again, these are women, that have fairly metastatic disease. So an extra year. Yeah, it's significant. Yes. For women with homologous recombination deficiency, veliparib gives you 31 months versus 20 months in this study. Okay. So again, close to another year. Yeah. Yeah. So what's so important to keep in mind there really is that there's so much new information and new treatments, and then new ways of using existing treatments for certain genes and certain combinations. That if you're watching combinations, that's really where it's at.
Yeah, because there's so many options then for different treatments, and an extra year might not sound like a lot. Maybe it does, maybe it doesn't. But a lot can happen in that year in terms of new information that allows your doctor to offer you new treatment options, or again, existing ones, but that are now shown to be beneficial for different purposes.
And I think that's an excellent point that you just made, that I didn't specify, but the data I was just sharing was based on just the drug alone, single agent. Okay. Very few drugs work good as a single agent. They almost always combine with other drugs or chemo or different targeted therapies. So even if the drug is getting those kind of results alone, it's going to be a lot better with other combinations.
Right. And if you know the genes that are driving your cancer, then you'll be able to have confidence that you're getting the right combinations. Right. And so that number you just gave should be significantly increased for a lot of people. Yes. Yeah. Okay. All right. So that's a lot of information.
We've got more. Okay. And so of course we can't, we have to stick with checkpoint inhibitors with just about every cancer we look at.
Why?
Checkpoint inhibitors are immunotherapy once again.
Okay.
PD-1 inhibitors.
Thank you.
So a recent study called the Keynote, and all PD-1 inhibitors are basically, or most of them are based on the Keynote studies.
Okay.
So for advanced recurrent high-grade ovarian cancers, there's about a 9-10%. Now in these patients, 9-10% response rate. However, if they have a higher PD-1 level, over 50% PD-1 positivity, then they get a much better response. And this is PD-1 positivity specifically in their immune cells, not necessarily the tumor cells. Okay. So that's important.
Right. So that's an important distinction. Yes.
Yeah. Now, what else is being used quite a bit, and I mostly see this in the States a lot, is a drug called, it's actually radiation therapy on microspheres called yttrium Y90.
Okay.
And basically what it is these microscopic glass spheres that are coated with radiation with yttrium-90. And what they do is they inject them into the liver, and they just stay in the liver. And they seem to work quite well for ovarian cancer metastasis. So that's definitely an approach to consider. I don't see a lot of it in Canada, although yttrium-Y90 is available in Canada. It just doesn't seem to be used as much as other countries, the States and so on.
But if you had evidence to show it was going to be beneficial for you, you could make an argument
for liver metastasis specifically. Yes.
It's and
I'd like to finish up with a very exciting new drug, which is what we call the Trojan horse strategy.
Okay. Go ahead.
So this is basically what we call an antibody drug conjugate, and we're seeing a lot more of these.
Okay.
So there's a few different players in the market now.
Antibody drug conjugate.
Yes.
Okay.
Yes. So you have an antibody that seeks out a cell surface feature that's unique to the cancer cells and brings with it this chemotherapy drug. And so the antibody binds onto the cell and then it drops this chemotherapy payload. So that's why we call it the Trojan horse effect.
Okay.
So there's a new drug now for ovarian cancer called mirvetuximab.
Okay.
And so anything that says MAB on it, it refers to a monoclonal antibody.
Okay.
So this drug is basically, antibody conjugate. We call it targeted chemo because it actually targets cells rather than just dumping chemo into your blood. The antibody helps the chemo drug target to the actual tumor cells.
Wow.
Yeah, so it's quite fascinating. And so in this case, the drug has a couple different components. Okay. It's got something called a DM4, which is attached to a SPDB linker called suravanticine.
Okay.
So this is getting into the technical areas.
It is.
So basically what this means is that it has this linker that connects the drug and the antibody. In this particular case, this linker basically is unaffected in the bloodstream, but once it gets to the tumor, the linker itself also has a bystander effect. In other words, it causes some sort of, we don't know if it's an immune response or what, but it has what we call a bystander effect, and it kills other cancer cells, just the linker itself. So this is just the thing that attaches the antibody and the drug together. So now you have the antibody, which binds the outside of the cell, can also cause an immune response because something's attached to it.
Right. It's
Then
going
you have
its attention.
It's going to get its attention. Then you have the drug payload, and then now you have this linker too that also has some sort of cancer-fighting property.
So triple targeted.
Triple targeted, yeah. And so it targets something called the folate receptor alpha. Which is highly expressed. I think it's about 75-80% of ovarian cancer cells, high-grade ovarian cancer cells. Okay,
so it's definitely looking for something that's there and needs to be looked at, right?
Yes, exactly.
Wow, that's it. What's that called again? Folate?
Folate receptor alpha.
Okay. Wow. And this is the mirvetuximab.
Yeah, mirvetuximab.
Mirvetuximab. Okay.
And so as a single agent, now, as you know, just single agents don't have the best efficacy. They have to typically be combined with chemo or other drugs. But as a single agent, it had a response rate of 47%, which is fairly significant.
Yeah.
It's well tolerated. Side effects with these Trojan horse drugs are kind of unique. They're kind of rare and unique. They're not what we see in other drugs. So one of them is you get the sloughing off of cells in the cornea of your eyes, stem cells. These, I guess, is something to do with this receptor, but we see this in other drug conjugates too. And you see the sloughing off, and so patients get a blurry vision.
Oh.
And they get really concerned, and it causes something called, and I had to look this up because I've never heard of this, corneal microcysts, which is just a fancy term for debris. And so if you go into an eye specialist and you have these corneal microcysts, they're going to get very concerned because it often leads to blindness.
Okay.
But in this particular case, what it is it's just a side effect of the drug and is of these stem cells sloughing off into the cornea.
Right.
And as soon as you stop the drug, it goes away 100%. So it's 100% reversible.
Okay.
So it's a scary side effect, but it's not that bad.
Okay.
You can also get diarrhea from these drugs,
Mm.
and dryness in your eyes too. So you can use these droplets in your eyes and to take it away. But I mean, that's a lot better than
Then losing your hair and all the
yeah.
nausea and.
I have heard stories of neuropathy too. I'm not sure about mirvetuximab, but
Okay.
I'm sure there's a little bit of nerve damage because it is a chemo drug.
Okay. But still.
But I think we're going to see a lot more of these.
Yeah.
There's a great one for HER2 positive breast cancer called TDM1. We discussed that a few videos ago. And these drugs really are going to play a significant role in cancers. Targeted chemo.
These Trojan horse
drugs, yeah. Antibody drug conjugates.
Yeah, because they're so targeted.
Yeah, exactly.
And, they're doing a whole bunch of different things.
Definitely.
Yeah.
Yes.
Oh, wow. Okay, great.
So that's it.
That's it
all
for
I
now.
have for now.
All right. Okay, so we've covered three main types of ovarian cancers, and we've talked about some symptoms and things to do, treatments that will work well, things you can add to existing treatments. So that's very helpful. I think you've given the viewers at home a lot to work with.
And take home question. Get sequenced.
Get sequenced.
Always
right.
get sequenced.
Right. Yes. So that fun. Yes. And we can go into this another time. But when you're talking about sequenced, you mean having a tumor biopsy tested with a good quality genetic test.
Yeah, Foundation 1 or Caris or something like that. Yeah.
Or
MSK Impact.
A blood-based.
There's a bunch of great ones.
Yeah. Okay.
Thank you for watching Cetome TV. Subscribe below and stay informed.